Welcome to the Multiple Sclerosis Virtual Grand Rounds. This is a series of case-based educational modules on important topics in multiple sclerosis and related disorders. I'm Alex Rae-Grant, a staff neurologist at the Mellen Center for Multiple Sclerosis and director for this course. In this segment, I am pleased to present Dr. Brenda Banwell, Chief of Neurology at the Children's Hospital of Philadelphia and an internationally recognized expert on pediatric multiple sclerosis. She will be talking about our updated understanding of pediatric MS in terms of the clinical, MRI, and treatment response of this small but important group of patients. We chose this topic for the series in recognition of the great work that Dr. Banwell and her colleagues have done to extend our understanding of MS in the pediatric population. They have clarified the complexities of diagnosing MS, particularly differentiating from ADEM, as well as the differences in clinical course from adult multiple sclerosis. They have also begun to elucidate principles of treatment in this group where we have much less data to go on than in the adult population. If any of you still believe that children are just little adults, I'm sure that Dr. Banwell will convince you otherwise.
Thank you, Dr. Rae-Grant, for the opportunity to present on the topic of pediatric multiple sclerosis. My name is Brenda Banwell, as you've heard, and I run the Pediatric Multiple Sclerosis Program here at the Children's Hospital of Philadelphia, and I'm going to share with you clinical and research data that has been derived from the pediatric program at the University of Toronto Hospital for Sick Children and our Canadian National Program, which has been in operation since 1999. So first, I'd start with the story. I'm going to present to you a 16-year-old boy who was previously well, cognitively normal, who in July of 2008 presented with progressive bilateral lower limb weakness that worsened over the course of 2 months. He had a 1-month history of bilateral sensory loss in the lower limbs. He denied bladder impairment, and he described generally feeling fatigued for about 6 months. He was born in Africa and immigrated to Canada at the age of 2 years. On exam, he was alert and, again, cognitively normal. His visual acuity was mildly reduced in the right eye and normal in the left. He had a partial right sixth nerve palsy, which he had not noticed and did not describe diplopia, a right lower motor neuron facial weakness. He had an upper motor neuron pattern of weakness in the left arm and bilateral lower extremity weakness and was actually unable to safely ambulate. He had upper limb dysmetria bilaterally and a sensory level that localized to T4. The image shown here and highlighted by the red arrow indicates an area of increased T2 signal in the spinal cord at approximately the C5, C6 area in the present image. And as well, he also had brain imaging findings that show multiple areas of increased T2 or flare signal. You can see in the first image, which is a sagittal image of the brain, an ovoid-shaped lesion, as well as multiple lesions emanating from the corpus callosum. And on the axial image to the right, you can see multiple areas of relatively well-defined ovoid lesions located in the deep white matter, in the periventricular white matter, and at the juxtacortical border. So what is your diagnosis? A, multiple sclerosis. B, neuromyelitis optica. C, HTLV1 infection, or D, post-infectious myelitis. I'll continue now with his story. His initial Expanded Disability Status Scale score, or EDSS, was 6.5. He was admitted and treated with intravenous solumedrol, or methylprednisolone, with moderate improvement. He was able to ambulate, he still had bilateral sensory deficits, and he required a cane for stability. Over the next 2 years, he had 3 further relapses, one with optic neuritis, one with, again, spinal cord symptoms, and a third relapse that was mostly sensory and localized to the cerebral sensory cortex as opposed to the spinal cord. He was initially treated with interferon beta 1A subcutaneously, or Rebif, which he did not tolerate due to flu-like symptoms, and was switched to glatiramer acetate, or Copaxone, 20 milligrams subcutaneously daily. In 2010, he traveled to Egypt, where he underwent venoplasty based on the chronic cerebrospinal venous insufficiency theory that was fairly popular for medical tourism at the time. So he gives an overview of some of the things that we have noticed in our pediatric relapsing remitting multiple sclerosis patient population, which is that, first of all, many of our patients, particularly in Canada, come as first-generation Canadians. 2, he had 3 relapses in the first 1 to 2 years of his disease, a fairly high relapse rate, which is characteristic of pediatric onset patients. Atypical of my patient population, he had poor recovery from his initial relapse. Most children, about 85%, recover completely from their initial attacks, but he had a rather significant spinal cord attack. And I should mention that the C6, C7 lesion that I illustrated was only one of several lesions in his spinal cord. I will discuss some of his therapeutic strategies a little further in the talk. So the current slide illustrates some of the concepts that are important when considering multiple sclerosis in both children and adults. But for today's talk, we're going to focus on pediatrics. The first comment I would make is that in the yellow section, you see the typical clinical course of a relapsing remitting MS patient, where they are previously healthy with an unknown duration subclinical phase, followed by episodes of clinical impairment, illustrated by the heightened bars, followed by partial or complete recovery from each of these episodes of attack. Over the course of time, illustrate here at 10 years, but in children perhaps more appropriately closer to 20 years, the patient develops increasing physical disability, as illustrated by the rising bar on the rising line on the right in yellow, in the absence of clear relapses, and that phase of the disease is referred to as secondary progressive multiple sclerosis. In children, relapsing remitting disease from onset is the typical clinical course. Over 95 to maybe even as high as 98% of pediatric MS patients have relapsing remitting multiple sclerosis at onset. Primary progressive multiple sclerosis, which is an illness characterized by progressive disability from the time of first presentation, is exceptionally rare in children, and I will not discuss that further today. Any child with progressive neurological impairment in the absence of discrete attacks should be more thoroughly investigated for inherited white matter diseases or other etiologies, as this would be considered so atypical for pediatric onset multiple sclerosis. In the second part of the panel, we see the current concepts of the biology of multiple sclerosis, the blue representing the peripherally initiated inflammatory injury, and the red, the degenerative or perhaps CNS compartmentalized, I can't say that, inflammatory injury. You'll notice that on the far left of that middle panel, there's a small piece of red. The idea that the degenerative biology of multiple sclerosis may start earlier than previously hypothesized is an important area for the pediatric multiple sclerosis population to explore, since our patients present clinically rather uniquely close, we believe, to the biological onset of the disease. And I'm going to show you some evidence that, in fact, the degenerative aspects of multiple sclerosis do indeed start early. And finally, the third panel of this diagram illustrates the MRI features of multiple sclerosis in both children and adults, which are areas of increased T2 signal that increase in their frequency and accumulate over time, as well as illustrated by the little arrows, multiple MRI scans where there is at least one enhancing lesion, enhancing lesions being indicative of new disease probably within the last 4 weeks prior to the image. On the next slide, there are a variety of concepts as to what might initiate the MS disease process. MS is considered an autoimmune disease, or a disease in which the host immune system attacks the patient's own tissue, in this case the brain and spinal cord and optic nerves. And the inciting biology of this process is thought to be an interaction between host genetic predisposition, most eloquently captured by the human leukocyte antigen or HLA phenotype, but also by other MS risk genes, each of which contribute a small fraction to MS risk, followed by a series of environmental exposures that appear to contribute to the overall risk of MS outcome in an individual. These environmental exposures are not fully understood, but certainly low vitamin D, Epstein-Barr virus and other infectious triggers, potentially minor tissue injury or head injury, and altered host immune responses are thought to be contributory. In children, the first attack of demyelination, which we refer to as an acute demyelinating syndrome or ADS, can manifest in a variety of ways. The first attack may be similar to our first patient with transverse myelitis, as shown in the first panel. Can be a dramatic and often life-threatening illness with diffuse multifocal central nervous system and spinal cord involvement in patients with encephalopathy or profound impairment of consciousness and multiple neurological findings, disorder called acute disseminated encephalomyelitis, or ADEM, in the middle. A child may present with optic neuritis, and you can see on the panel illustrated there the arrow pointing to an area of increased T2 signal in the optic nerve. Children can present in the lower panel with involvement of the brainstem and multiple findings related to the localization of that area of inflammation. And finally, as illustrated on the far right, children can present with their first attack and multiple areas of involvement, again, similar to our patient, who had clearly both brainstem and spinal cord involvement. And not surprisingly, there were multiple areas of subclinical, clinically silent involvement in the brain as well. So children present slightly differently based on their age. So the youngest patients are more commonly manifest with ADEM as their first attack of multiple sclerosis. And I'll pause here to comment that ADEM as a disorder can be, and is most commonly, a monophasic single illness of early childhood that typically does not go on to multiple sclerosis as a diagnosis. Most of the children recover well. However, an attack that looks like ADEM, again with encephalopathy and multiple neurological deficits, can also be the first attack of multiple sclerosis in the pediatric age group, which makes this a very difficult clinical situation in order to prognosticate. And I will share some prognostic hints with you a bit later. In older children, it is more common for the first MS attack to be monofocal. In other words, the findings are clinically, but not radiographically, localized to a single place in the central nervous system, such as the optic nerve, spine, or brainstem, or polyfocal, where the child presents with multiple findings that clearly implicate more than one area of involvement of the disease at onset. Overall, about 20% of children with a first demyelinating attack will be confirmed to have multiple sclerosis on the basis of both MRI and clinical further disease within 2 years of that first attack. And as one interesting point, 67% of children with optic neuritis, even if they have one clinically silent brain lesion, will be diagnosed with MS. Transverse myelitis as a first attack is a less likely clinical scenario to lead to a confirmation of multiple sclerosis, but about 20% of such children are left with residual gait impairment, reminding us how serious it is to have inflammation in the spinal cord. And as I said, an ADEM-like attack may be the first attack of MS in a young child. There are National MS Society Working Group definitions for the diagnosis of multiple sclerosis in the pediatric age group, obviously predicated on the patient being 17 years, 11 months, or younger. And just like adults, two clinical attacks that are separated in time and space and involving different areas of the central nervous system are sufficient for the diagnosis of multiple sclerosis, provided other diagnoses are excluded in the differential. There are also ways to utilize neuroimaging to assist in the diagnosis of multiple sclerosis. I've listed some here, but I'm also going to speak to the recent modifications, which are referred to as the 2010 McDonald MS diagnosis criteria, in a few moments. I want to illustrate one of the ADEM-like first attack MS scenarios for you, since many of the adult neurologists on the call may not be as familiar with this presentation. So this is a little girl who presented at 8, previously completely healthy and cognitively normal, who came in with acute onset confusion progressing to coma. She had multiple findings on exam, which of course varied related to her degree of overall level of consciousness, but when able to be examined, she was clearly ataxic. She had lower extremity weakness. She had brainstem findings. And her first image is shown on the bottom left, which illustrates ill-defined bilateral areas of bright signal on flare. She was treated with intravenous solumedrol, and by 5 days post-presentation to the hospital, she was completely normal. 14 months later, however, she presented with a new attack characterized by optic neuritis and has had 12 further MS attacks and is now 16. And I think her images illustrate a few key points. One, the initial ADEM-like presentation had images somewhat atypical for classic multiple sclerosis. The middle image shows near complete resolution of abnormal signal, a finding that is rarely seen in adult onset disease. And the far right image shows focal areas of bright signal more typical of adult onset multiple sclerosis. And we've seen this quite commonly with our very young MS patients as they mature, developing MRI changes that are also, I guess you would say, more mature and look more like adult onset disease. And just to illustrate that point further, the typical MS image shown here is that of a 14-year-old boy with relapsing remitting multiple sclerosis. And the ADEM picture I illustrated earlier is from a patient who had dramatically severe ADEM and a monophasic slow but complete recovery. In the spine, multiple sclerosis is more typically characterized by the focal rounded lesions, such as those by our patient, whereas in ADEM and also in an entity that I won't be discussing today called neuromyelitis optica, the spine images are often characterized by very long lesions bracketed by the arrows on the image on the right with a diffuse cord edema and swelling. Children with MS have an early course of disease that, while characterized by relatively frequent relapses, is rarely characterized by early disability. As you can see from this paper from Dr. Renaud and the French group published in the New England Journal of Medicine, the onset of MS in childhood is associated with a later onset of fixed physical disability. It takes longer from first attack for a child to acquire fixed disability, but if you look at the median age, or the 50th percentile, when patients are likely to demonstrate disability, you will see that the age of those patients is only in their mid-30s. So therefore, while children may take a longer time from first attack to the point of acquiring fixed disability, they end up doing so at a much younger age, in reminding us that MS onset in children is far from benign. Similarly, as I mentioned earlier, the onset of secondary progressive MS, not only the physical disability consequences of this phase of the disease, but also the increasing disability from independent from attacks, happens after a longer disease duration and younger age in the pediatric onset patients, again reminding us that pediatric MS is a serious illness. So I'm now going to move to a little bit of our research. And what I will be discussing is representative of a program that I've been privileged to serve as the PI for since 2004. And this program is referred to as the Canadian Pediatric Demyelinating Disease Study. We've now expanded it to include my new location here in Philadelphia. And my co-principal investigators, Dr. Barr Orr in Montreal from immunology, Dr. Arnold in neuroimaging, Ruth Mari in Winnipeg from statistical analysis, and Dessa Sadovnik in genetics, and I have put together a program that links clinical, genetics, imaging, immunology, and complex modeling to evaluate the clinical presentation and risk determinants for MS outcome in children. So our patients are enrolled at the time of a first demyelinating attack, ideally within 24 hours, but certainly within the first 30 days, keeping in mind the fact that these children are enrolled at 23 centers across the country. They are evaluated using standardized metrics and structured imaging at 3, 6, and 12 months, and then annually, and we are now approaching our 10th year. Children are also re-examined if they have a second clinical event. In 2011, we published our first 5-year data on this cohort, where we put together the clinical and genetic determinants as well as some environmental exposures of MS outcome in children with that first demyelinating event. Of 332 children, we had 30 that were excluded, 18 of whom had diagnoses that were not primary acquired demyelination. And since we tried to enroll within 24 hours, we did anticipate having approximately a 10% rate of alternative diagnoses, given that most of the results of these confirmatory diagnoses would not have been available in the first couple of days of illness. Subsequently, of the 302 eligible children, 63 at the time of this slide had been confirmed with multiple sclerosis. 8 had had a second attack but did not, strictly speaking, meet the diagnostic criteria for multiple sclerosis. And 231 have been monophasic to date in terms of clinical activity, clinical and MRI activity. This slide's a little bit busy, but just to walk you through it, the blue bars refer to our pediatric MS patients, and you can see that the presentations include very rarely ADEM, so very few children with ADEM have been diagnosed with MS to date. Whereas optic neuritis, monofocal other locations such as brainstem and polyfocal presentations are more common in MS patients in both the younger, less than 11, and older in the darker blue age groups. In children with monophasic demyelination, of course, we see a high representation of children with ADEM, as one would expect, and a fairly equivalent based on age presentation across the other presentations. Now, we thought it would be valuable for clinicians to have a guide to use when at the bedside early in the disease course, so at the time of a first attack, when parents ask you, what is the likelihood that my child will be diagnosed with MS? So we looked at our data, and based on the findings that we have, we show that at the time of an acute demyelinating event, if the child has has a brain MRI that does not show any T2 lesions, in other words, a child with optic neuritis or a child with transverse myelitis in a normal brain image, the likelihood that they will be confirmed to have multiple sclerosis is very low, just short of 2%. In contrast, if they have even one clinically silent T2 lesion on the brain MRI, their likelihood of MS outcome is much higher. If they are younger, and the 11.85 years was a statistical tipping point, if you will, if they're less than 11.85 years and had ADEM as their presentation, all of these children, of course, have multiple white matter lesions, their risk of multiple sclerosis is 3.3%. If they have clinically silent lesions under the age of 11 years on their imaging and the non-ADEM presentation, their risk is 28% to date. And the highest risk is for children who are older than 11.85 years and have even one silent brain lesion, where their risk is almost 61%. The lower risk in the younger children, I will say that the French group have indicated that MS outcome in pediatric patients presenting prior to the age of 11 can be several years before one can confirm that diagnosis. There seems to be a longer inter-attack interval. So like any prospective program, we are always reminded that the long-term outcome of our patients is our key outcome measure, and our study is now entering, as I said, into our 10th year. So why this child? Parents ask this every time. Why did this happen to my child? And I will share with you a little bit of data on environment and genetics. This is a busy slide from the paper, and I will not expect to go through all of it with you, but on the far left, I have illustrated the different things evaluated in our cohort and their relative hazard ratio or contribution to MS, likelihood of MS subsequent diagnosis. The most predictive, as you might have expected, is the greater than 1 silent T2 lesion with an almost 38 times increased likelihood that a child with that finding will have confirmed multiple sclerosis within the first couple of years post-presentation. Oligoclonal bands lead to a 6-fold increase in likelihood of MS outcome. Epstein-Barr virus infection, in other words, a remote infection, is 3.39 times more likely. There's a relatively modest contribution of HLA-DRB15, which is the highest risk allele for MS in Northern European populations. And finally, there's an inverse relationship where higher vitamin D levels are associated with lower likelihood of MS outcome. When we look at the viral data in more detail, you can see that there is a very powerful relationship between prior Epstein-Barr virus exposure and MS outcome, and this has certainly been shown very clearly in adults, and there is ongoing work now in trying to understand what Epstein-Barr virus might be doing to convey such a increased likelihood of MS outcome. There appears to be a potential slightly protective role for cytomegalovirus, or CMV, which also requires further biological understanding. When you look at the patients that had Epstein-Barr virus and not CMV, so the the lowest line on that graph, you can see that these are the children most likely to be confirmed with multiple sclerosis, suggesting that it may not be a single virus that's relevant to MS risk, but in fact maybe your viral exposure history and the relative contributions of different viral exposures at different key points that may contribute to risk. When we looked across all of our patients, I think it was interesting to take the highest risk factor trio, if you will, at least based on adult data, and see how they contributed to the likelihood of MS outcome. So in the red box, we have patients that have the triple hit of being HLA-DRB15 positive, having had remote Epstein-Barr virus infection, and having a low serum vitamin D value. And I apologize, these are in Canadian units. And we had 28 children with that trio of risk, and about 57% have been confirmed with MS to date, and 43% have not. This reminds us that the risk determinants for MS alone are not enough, indicating either that there are other risk factors not yet captured, or that these risk factors are potentially important but not sufficient. In the green box, we have children, 20 of them, who had none of these risk factors. So they did not have the HLA alleles, they did not have Epstein-Barr virus infection in the past, and their vitamin D levels were sufficient. And you can see that to date only one of these children has been diagnosed with MS, suggesting that the absence of risk factors may indeed be highly protective. So our key findings in the study to date are that children with MS are 38 times more likely to have had at least one clinically silent brain lesion at the time that they present with their initial presentation. And if you combine that with oligoclonal band positivity, they are 45 times more likely to be diagnosed with MS. This is clinically helpful for you when counseling families. Epstein-Barr virus and vitamin D are also important and raise interesting questions that might be relevant at the population level for future strategies for reducing the risk of MS at the population level. So I'm going to move to the end of the last section of my talk, where I'm going to show you some pictures of what MS looks like in children. You have seen pictures already of the T2 areas or areas that are increased on T2 or flare, as shown here on the upper left part of the image. Children, just like adults, can have lesions that enhance with gadolinium, and unfortunately, as shown by the green arrow, children with multiple sclerosis can have areas of T1 hypointensity, which represent areas of permanent tissue loss if those areas are present on multiple time points. And this is a 14-year-old girl with MS. The lesion distribution between children and adults is relatively similar, although children, as shown by the UCSF group here, tend to have larger lesions than adults. And if you image them close to the time of a first attack, may be more likely to have enhancing lesions, although I'm not sure that is actually true if you look at that over time. What we looked at was the relative distribution of lesions in children with multiple sclerosis, and I show here a heat map where we've taken 30 pediatric MS patients and 30 adults. We have computer merged them, and where things are bright yellow and sort of red are areas where lesions are particularly common across the group. And in the top part of the panel, you can see that the brainstem, particularly the pons, lights up in the pediatric MS patients and less so in adults, illustrating a finding that has been now relatively consistently found, which is that children tend to have a fair bit of brainstem disease. Whereas supratentorially, you can see that both children and adults have periventricular predominant areas of lesion involvement, and I might be able to convince you that the adults are slightly brighter yellow than the children, indicating that adults tend to acquire even more periventricular disease than children when matched for disease duration. These are all 4 years out from first attack. I've already illustrated this issue of disappearing lesions in pediatric patients. The images at the bottom are the little girl I shared with you, who is my patient, but this was also noticed by another group at UCSF in their patients as well, a very distinct finding in the pediatric age group. As I mentioned to you earlier, the 2010 McDonald criteria now permit the diagnosis of multiple sclerosis in patients with typical first attack presentations, provided that the MRI also shows clinically silent lesions in areas that are commonly affected in multiple sclerosis, so periventricular, juxtacortical, brainstem, and spinal cord, as illustrated by the arrows on that image. And you can confirm using a surrogate for disease separation in time the presence of both an enhancing and non-enhancing clinically silent lesion. This criterion was put in for two reasons. I had the privilege of being on this 2010 panel, and the discussion about the importance of an enhancing lesion at onset that's clinically silent is that it does indicate an area of active inflammation separate from the clinical presentation, and the presence of non-enhancing lesions suggests that there's been some variability in time. Furthermore, enhancing lesions at onset are highly predictive of subsequent relapse, and that's why that criterion was put in the 2010 version of the diagnostic criteria. We have evaluated the applicability of the 2010 criteria in pediatrics in a cohort summarized on the next slide. So of 212 patients for whom we had serial imaging and clinical evaluations for more than 2 years in order to hopefully carefully capture them. We divided those patients into those with ADEM at presentation and those who did not have ADEM at onset. And when you read the 2010 paper, you will note that in our deliberations, we specifically expressed concern that the 2010 criteria might not apply to patients with an ADEM first attack. When we evaluated this, in fact, we were correct. The 2010 criteria, in summary, are quite good and very sensitive and specific at identifying at baseline those children likely to have further relapses or MRI evidence of new attacks and new lesions over time. And this was particularly useful in children that were over the age of 10. The McDonald criteria do not apply well in the context of ADEM because children with ADEM have lesions that are often in multiple areas and may have one or more lesions that enhance. And as I've shown you earlier, about 95% of children with ADEM, if carefully characterized, have a monophasic disease. So the 2010 criteria baseline should not be used in a child with ADEM, but in children with non-ADEM presentations, the 2010 criteria appear to be appropriate in the pediatric age group. I'm going to finish by showing you a few things that have been quite concerning to us, and that is that when we evaluated brain volume in our pediatric onset MS patients, we have found that the brain size, and this is corrected for age using a partnership with the National Institutes of Health normative brain data, a collection of about 560 healthy children imaged at multiple time points. We were able to partner with that data set to show that in Table 2 on the top right, that the normalized brain volume, or NBV, is about 1 standard deviation below age-expected values in our MS patients. And if you look down to the NTV, or normalized thalamic volume, it's about 1.17 or 1.2 standard deviations below what one would expect when normalized for head size. What this means is that the brain size of our pediatric patients falls below what one would expect for age, suggesting that they potentially have already lost brain volume even during the pediatric age group. We even noticed a change in overall head size, and since our skull growth is largely completed prior to puberty, reduced head size suggests that this process may have started in our pediatric patients even before their first clinical attack, or certainly during that final formative stage of overall brain and skull development. We have shown a correlation between the thalamic volume and full-scale IQ, which you can see on the right-hand plot for the MS patients. So as the thalamic volume goes down, so too does the full-scale IQ performance, whereas on the left panel, the healthy children who have normal thalamic volumes show no relationship with their full-scale IQ, suggesting that their thalami are of perfectly adequate size to function normally cognitively. So we are showing some early functional volume relationships, which again indicate potentially that this loss of brain volume has fairly significant clinical consequences. Similarly, here we've looked at cross-sectional area of the corpus callosum, illustrated in pink, and the top circled point is the child up on the top right. The bottom circled point is the child on the bottom left, and you can see that their performance on what's called the symbol digit modality test, which is a speeded task of performance. As speed goes down, so too does the size of the major white matter trajectory, the corpus callosum, also indicating that as you lose tissue volume, you lose function even in the pediatric age group. We have shown this also, the same test, the symbol digit modality test, with thalamic volumes, which is not illustrated here. This is just the plot now of the integrity of the corpus callosum. So here we use diffusion tensor imaging to evaluate not just the size of the corpus callosum in our prior image, but here using diffusion tensor imaging, we're looking at tissue microstructure. So as the fractional anisotropy, which is a measurement of just how well aligned a tissue is, goes down, so too does cognitive performance, suggesting that not only is the corpus callosum smaller than it should be for age, but the residual tissue left in the corpus callosum may not be as well ordered or as well structured as it should be in healthy children. So I'm going to end with one final thought. I have illustrated to you some of the shared and some of the distinct clinical and imaging features of MS onset in children. But what matters most, I think, to all of us as we manage our patients is to think carefully about how we can apply strategies for therapy to optimize their current care and hopefully to mitigate against some of these deleterious factors as they progress during childhood. the paper illustrated here is a review manuscript illustrating some of the things that one might want to consider when treating children. I'll say first that to date there have been no formal trials in the pediatric multiple sclerosis age group, although I believe these will be coming soon. And all of our data on therapy is extrapolated from data in adults and summarized by case series and collaborative multi-center case series reports. The emerging new therapies, particularly those that are administered orally, will have great appeal to pediatric patients, just as they do in adults. But it is very important to consider the impact and mechanism of action of these therapies. Oral does not necessarily mean safer. The definition of an inadequate response needs to be defined for all MS patients, but never more importantly than a young child who may have aggressive frequent relapses and potentially be offered in sequence multiple different therapies such that they end up with limited repertoire of residual choices at a very young age. We need to consider, both for trials and for our own care, what outcome measures we use to define treatment efficacy. Both clinical relapses but also the MRI are obvious choices, but we need to be careful that we consider those choices in light of the natural history of MS in children, not necessarily extrapolated solely from the data in adults. Can we use cognition to monitor therapy, and if so, what measures are reliable? And should we use something like cognition that was not a primary endpoint in most of the therapeutic trials in adults? I would hope that all of us will share the view that safety monitoring is essential, and it worries me that because pediatric MS patients are treated off-label, that in fact they may be availed of less surveillance, not more, compared to adult patients who are potentially more likely to be enrolled, at least initially, in trials. And I would advocate that clinical trials are superior to registries, but registries at least are far, far superior to off-label and of one use in the clinic. So to summarize, pediatric MS patients experience disease onset concurrent with or very close to their risk-defining exposures, providing us a unique opportunity to perhaps define some of these risk factors. Healthy age-matched children have a more restricted environmental repertoire, which again increases our power to identify factors more relevant to the pediatric MS patient, and also to run such studies in the smaller patient numbers that are, of course, essential given the rarity of MS onset during childhood. By virtue of their young age, pediatric MS patients at the time of a first attack have had a limited capacity for preclinical disease, and thus allow us a chance to determine whether or not the degenerative biology of MS may indeed truly occur at disease onset, and to measure immune responses, which I have not discussed today, which may provide information on what is truly the earliest target of the abnormal immune response that characterizes MS. We believe that these early signatures have the potential to inform on different therapies, and I would suggest to you that both our neuroimaging studies and the cognitive findings in our patients suggest that neuroprotective strategies, which are eagerly sought for all MS patients, may need to be applied at disease onset and certainly need to be applied in both the pediatric and adult patients. And with that, I will conclude and acknowledge that the work I've presented today and the team with whom I have had a chance to complete this work have been absolutely instrumental in creating a pediatric multiple sclerosis program. It is my privilege to represent their work and also to thank the Multiple Sclerosis Society of Canada and its foundation, as well as the Canadian Institutes of Health Research and the Institute of Medical Science at the University of Toronto, who have funded all of the things that I've mentioned. Thank you.
Thanks, Dr. Banwell, for your helpful and cogent talk. For adult neurologists, the observation MS can begin with an ADEM-like attack may come as a surprise. The role of MRI lesions and presence of oligoclonal bands in predicting progression to MS after first attack will, however, echo the experience in adult forms of MS. In terms of the MRI difference, recognizing that patients may have more infratentorial and larger lesions than adults will be helpful in the recognition of this disease. Your group's observation on thalamic volume and IQ are groundbreaking. Begin to get at some of the gray and white matter relationships in this disorder. Most of all, you've shown that an international, multi-center approach to this low-frequency but important disease can yield important data to guide diagnosis and therapy in the clinic.